Thank you so much, Eileen, and thank you, Kathy, for your kind words. And also thank you to Pulse New York, your board members who are well represented tonight, as well as people for patient safety. And thank each of you for taking time out of your evening to listen to what I have to share with you. I really appreciate it. It's good to see some old friends participating. Thank you, and nice to meet all my new friends. So thank you so much. I want to just share a little bit more about me, and I won't read through that. I'll just say I practiced internal medicine mostly here in Alabama, where I am tonight, over 20 years, and I have worked on equity and disparity. I would really say all my life. What you'll see here is some of the activities that I'm currently involved with, or have been involved with over the years, and I just share that to kind of share my background on these topics. And I'll say that while I'm actually still learning more and more about these topics and what we need to be doing as a community. Really nothing to disclose. And I'm just in for transparency, and I appreciate it, Eileen, for saying I have another engagement. The truth is the Alabama football game starts at 7:15. So it's not like there's something.
That's great.
So I just want people to know that, it's not something more than that. So again, I ask that we all think and listen and share with humility as we all try to understand some of these topics. There may be times in the presentation that you may feel uncomfortable. Usually that's one of my learning objectives is around these topics is that people begin to feel a bit uncomfortable in a good way. So I'll just start here by saying as we go through the presentation in this graphic, what it tells us is that health happens where people live. It happens in the community. And while we have historically thought about clinical care and in some cases rationalize the care that people receive as somehow genetic or biological, you'll see that that's just 20% of what happens in health. The rest of that happens in the communities where people live, where people work, where they learn, where they love. And that's, I think, where the patient advocate's role is so important to understand these factors that impact a person's health. I think as we think about that, I try to always lead with some type of story. And as I share this story, I would ask that you think about the topics that I will present to you. And there's no way I can get deeply into all of these topics in the time we have, but I hope that you'll be encouraged and motivated to dig a bit deeper in some of these topics. So I want to start with the actual story, and this is her story. And this is a patient's story that I was actively involved with when I was at the Joint Commission and going through a root cause analysis. Her story was sent to me by about 3 nurses in the intensive care unit where this patient died. She was 52. She had been admitted to the neurointensive care unit at a big multi-system, well-known health center. In fact, the health center has a patient safety institute. She had a history of hypertension, type 2 diabetes that was poorly controlled. While she was in the hospital, I would just say that she likely had most of the hospital-acquired conditions that we're familiar with, including hospital-acquired pressure injury, hospital-acquired pneumonia, a catheter-associated urinary tract infection, and a central line-associated bloodstream infection. And when I had the time to talk to the system CEO at the hospital, I want to share with you some of that conversation. Here's a bit more about the patient. Patient identified as Black, Latina, had limited English proficiency. She had some behavioral health challenges, and there was a history of family discord. His story is the CEO that I talked with at this hospital. That conversation started like this. When he said to me, well, she was obese. He said she was non-compliant. He said that she was combative. And as I absorbed these words, instinctively, I said back to him, I'm a bit overweight. I like cookies, and no one's going to take my cookies from me. There are times when I don't keep my primary care appointments or change them for whatever reason. And there are times when I'm irritated and disagreeable. None of that gives anyone the right to disrespect anyone, or to not show compassion, or to not be empathetic, or to not maintain that person's sense of dignity and respect. So when we think through that, then there's some concepts that are key if we're going to achieve the kind of care and be the kind of advocates for patients and patients' families that we need to be. So as I go through the presentation, I will concentrate on these concepts: implicit bias, stereotype bias, microaggression, the concept of allyship, and then we will talk about racism. It's always important that we start and we ground ourselves with what I would refer to as operational definitions. So from the Curran Institute, then, when we think about implicit bias, and let me stop and say, we all have some type of bias, and we need to understand that. But these biases, implicit, are these attitudes and these stereotypes, and they really affect our understanding of people. It leads us to take certain actions. It leads us in a clinical setting in particular to make decisions that are made in an unconscious manner. The result of these mental associations and the lack of awareness, the intention or control can lead to conflicts even with our own conscious attitudes, with our conscious behaviors, with what we intend as a human being. The opposite of that is explicit bias, which is an attitude that somebody is consciously aware of having, and they act on that explicit attitude. So then in a clinical setting, when we think about implicit bias, here we're talking about when, here I say people of color, but that also includes what we would call the other isms. But when people of color receive some type of care that's different by medical professionals, and it's because of this implicit bias that's held out about particular populations, which includes myths and even physical racial differences. This usually results in people of color, but again, it could be across other populations, LGBTQ, disabled populations, both physical and cognitive impairment. I've seen it in rural, elderly, poor white populations, people who are incarcerated or formerly incarcerated. And it results in the complaints from these populations to, for some reason, being taken less seriously. The result of that then leads to harm. It's deeply ingrained in medical training, and we can go through many studies now that we can talk about, but one in particular was the one from 2016 of medical students at the University of Virginia. And in this study, it revealed that more than half of the students had endorsed at least one myth about physiological differences between Black people and white people, one including the idea that Black people require less pain medicine because the skin of Black people was thicker. More recently, this is a story of Amber Isaac that happened this year in 2020 in New York City during COVID. And this is around I think what we all know is just the embarrassing and shocking disparity in maternal health for Black and brown women. And it demonstrates what the Smithsonian has called the bias inside of us. When Amber spent months pleading with the doctor about her condition, her symptoms that ultimately led to Miss Isaac dying after giving birth, which again, we can go through the list of patients and the numbers that we know about in maternal health. So then we know that, as I've alluded to, bias takes many forms. It can be a disability. It can be something around where a person is from, what their language is, what their accent is, whether a person is introverted or extroverted. I mentioned sizeism, or the bias against people who are obese, or in a name. And that's famously, the famous example is from the so-called Chicago resume study, when young people were not called back for interviews if they had a name that sounded Black. There's biases against people with certain mannerisms, or they're thought to be their performance or their potential, or if there's something else about that person visually that leads to some decision that is rooted in some type of bias. And then what purpose does that bias serve us? In some cases, people feel like it guarantees or ensures or increases survival. It is an automatic survival tendency to maintain my survival, or the survival of my community and my population. And then there's this natural tendency to feel uncomfortable with people like us. We feel more comfortable, and we'll get back to that one later. So in terms of research, I talked about some of that, and the studies from medical school. There's a study here by Hoffman that involved, again, white medical students and residents. There is the cardiology studies that many of us may know about, where in these studies, if you put male or female who have similar or identical symptoms or presentations, you see gender bias. And we know that female patients get fewer procedures. Female patients get fewer knee surgeries or arthroscopies. And in one study, what the orthopedic surgeon said was the men get the arthroscopic knee surgeries more than women, because everybody knows that men are more active. And we can go on and on and on about maternal care and child care and how clinical decisions are made that's rooted in bias. This is a framework, and I won't go through that, but to say, as we think about implicit bias and its impact, we've come to a point where we have to really begin to think about what implicit bias training needs to be in health and healthcare settings. And again, not to go through these, but to say we're at that point now to say we have to act. And what I'll say next is, while many places have implicit bias training, that is not enough. It is not enough, but it's to be recommended that you have, at a minimum, implicit bias training. In most cases, that's a learning module. That cannot be a check the box exercise. There needs to be formalized education. This provides a good framework of how to go through it. And it goes through some of the things that are really important. How we create an environment for learning that feels safe. How we begin to understand the psychology of the systems that we work in as professionals, whether that's physicians or nurses or pharmacists or physical therapists or patient advocates. What is the psychology of the system that we're trying to help? What types of biases are working in that system, and have they been brought to the attention of people in that system? We need to understand deeply how these biases lead to disparities. They also lead, like in the patient I talked about, leads to errors and other patient safety events that leads to these poor outcomes, which includes readmissions, preventable injury, preventable harm, medication errors, and on and on and on. So then increasing awareness is what we're doing tonight, but it also requires, I would say, at a minimum, think about how to apply implicit association tests. And how do we increase mindfulness? And when I say mindfulness, that to me means we have to think beyond what we know of as cultural competency and begin to think about cultural humility, think about what's called structured humility in clinical settings. And that is not a one-off check the box kind of exercise. That is lifelong learning. That means we start to work on how we close the power gap between people being cared for in their families and the providers of healthcare or the healthcare team, so that that power distance is closed, so that there is an open sharing of information and knowledge and feelings that is not paternal in the way it feels. And that requires us to learn how then, as professionals, we self-regulate, that we don't take a implicit bias training course and then decide that I'm the expert on a person or a community or a population, that I still in a humble way seek to learn and to seek permission from that person or that population or that community, so that I can provide or be a part of a team that provides the highest level of care that we can provide in an equitable fashion. And I underscore all of this by learning what the absolute and critical importance is of empathy. And this can be measured. So building in empathy into this system of implicit bias training really becomes crucial and essential. One of the biggest parts of empathetic care is trust, and how we begin to build trust in populations that are distrusting. In particular, African-American men, is documented in research, have a high level of mistrust for the healthcare system. We talked about the North Carolina study. There's skepticism, there's fear, there's distrust, and particularly right now when we're in the pandemic and we continue to try to message and be present around the COVID vaccine, and how we build trust in communities that have historical reasons that I won't go deeply into, but historical reasons to not trust, historical reasons to be fearful of a vaccine or the message even about a vaccine. And the one that you all know about, and I'll mention it because I'm here in Alabama, is the Tuskegee syphilis trials, the oral contraceptive trials that were done in Puerto Rico on poor women who thought they were being treated when they were in a research protocol. We know the story of Henrietta Lacks. We also know the story of what's called the Mississippi appendectomy, which was perfected by Marion Sims, who's called the father of modern gynecology. And all of these stories, these historical perspectives live. We know that even recently, immigrant women were kept in an ICE detention camp in Georgia who were undergoing unnecessary gynecological surgeries. So there's a lack of trust that we need as a team to build. Part of the role as healthcare teams, patient advocates, patient and family advisory councils is to work together as a team to say, if there's one thing that is a huge liability, and as is put here, a death sentence for Black patients is a lack of trust. And we cannot be taken for granted. There has to be an action plan coordinated around how we build that trust. Here's an example of the Kaiser study called the Undefeated. And you can see the question there. And this is what we call a top box score around trust. And when you look at these numbers, they are alarming. So if you look at Black patients, 59% level of trust that they'll do the right thing most of the time or all the time. Hospitals, less than 60%. Police, 30%. Hispanic population, doctors, 72%. Hospitals, 62%. And I'll pause for a second to say, what hospital wants to have a patient population that believes that you will only do the right thing for them most of the time, all the time, at a 62% level? And then when you look at the white population, 70%, a top box score of 70% in a local hospital for doctors, 78%, that is an urgent signal that we really need to say to healthcare leaders, boards, and executive teams that we need to understand this deeply and how we work together as a team to impact the populations that we serve. Part of this that underlies these issues are stereotypes. This endpoint of generalization when people and all of us are prone to do this, make decisions about a person that's based on some type of mental picture that typically is some oversimplified opinion of a person, or it's a prejudiced attitude about a person or a group of people or a family, or it's an uncritical judgment of that person. And it rarely, I would say, does it really consider whether or not it fits the individual. But a decision has been made based on a stereotype that now impacts that person's care. And I will share with you the story I shared with someone earlier today about a patient that was under my care who was admitted, uninsured patient that was admitted when I was on call for what's called service. The patient needs to be in an intensive care unit here in the town I'm in now in Alabama. The patient was in the midst of surgery and was going from male to female, was in intensive care. The cardiologist came in for rounds one morning. I was there, the cardiologist not knowing that I admitted the patient the night before. The nurse manager on that unit, a friend of mine to this day, the nurse manager, black female nurse. The cardiologist saw the patient, came to the nursing station to start to write a note. The nurse was trying to tell him that that she was concerned about the patient's condition, that he was deteriorating. The cardiologist, who was a white male cardiologist, looked at the nurse and said to her, "Why do you care so much about him?" The patient no longer identified as a him. Why do you care so much about him? And I will have to give you the exact words he said because to me, they are to this day difficult for me. He said to that nurse, "Why do you care so much about him? He is nothing but a piece of poor white trash from Sand Mountain." I looked at the nurse. She had tears in her eyes. The cardiologist closed the chart and walked away. So you begin to think about the impact it has on that nurse, on her unit, on that patient, and frankly, to this day, the impact it had on me. We'll talk a bit about allyship a bit later, but in that moment, what I did is follow the physician and let's ask, "Can I speak with you for a moment? Let's find a quiet place." And I went over with him what this patient meant to me, that a patient trusts me enough to care for him, that patient needed us, that patient needed a team that was empathetic, that was respectful, that patient needed an advocate. The patient was alone. And I asked him, "Do you understand what that means?" He is fighting for his life. And there are many people, like the patient I shared with you about, who are fighting for their lives. They need to know that there are people that care. There are people that love them. There are people that will advocate for them no matter what. Insurance, no insurance, rich, poor, black, white, regardless. We have to move stereotypes aside and say, how can we love people and make decisions for people as a healthcare team that will hopefully avoid preventive injury, harm, and death. Part of this, and I'll share these with you because every one of these microaggressions at some point in my personal or professional career I've experienced. And as caregivers, as patient advocates, all of us need to understand what microaggressions are and how they function in everyday life, and what my friend David Williams up in Boston would call just the everyday racism, or the everyday discrimination, or the everyday insult that Arlene Geronimus calls weathering. that happens when these types of microaggressions take place. They can be a micro invalidation. And there's an example of that when you ask Asian person, where were you born? Or micro assault. And we saw some of that recently in racial epithets and white supremacist symbols and swastikas, micro insults. More than once, I've heard these words from a white physician. You are very eloquent, or you are a good speaker. Once a physician said to me, you speak almost perfect English. I've had physicians ask me, did I go to medical school on a quota or affirmative action? So we need to understand and be aware of what this means and the impact that it has on our care teams, on our the people we care for and their families. This is a bit about allyship that I talked about. As you'll see on the screen, I'm just honored to be in an ACGA, American Council of Graduate Medical Education Collaborative, and Dr. Nakai has spent time with us talking about allyship and how we can become allies and belong, and how as an ally we address harm. We began to dismantle structural inequalities, to stand up, to speak out, to want to know. And as I said earlier, how we began to lean into discomfort in spaces we've maybe never been in before, that we've never been truly an ally before, and that we integrate into this the ability to listen with humility, to believe with humility, to take a person like the one that I shared with you at the outset and say, what system was she in before she came into the hospital? What was her environment? If you go back to that first slide, what was going on in her environment? What was her housing situation, her employment situation? What kind of support system did she have around her? And then how we began to think through as an ally, as an advocate, how we stand in the gap for that person. And that's what, if you're an ally or a patient advocate, it's what we're called to do. So we're called to be an ally. That means you got to see things a different way. And you be the catalyst, and I'll share another story, being a catalyst for someone, to have a deep self-understanding of what this means, to self-reflect. What is it about me that I need to know and improve? And then commit. So there always has to be that commitment. So the story I share is, again, as a medical student in Birmingham at the University of Alabama, Birmingham. My first day as a third-year medical student, I went into a patient's room. The patient looked at me and started screaming to the top of her voice, "Get this N-word out of my room." And I said, "Ma'am, I'm a medical student." And she looked at me and she said, screaming again, "Get this quote unquote engine out of my room. Get him out." Then she started screaming, "John L, John L, John L, come get your gun, come get this N-word out of my room." Later that morning, the attending physician came on his rounds. By then, the nurse manager had spoken with my attending physician, who was a legendary internist, wrote chapters in books, later became chief of medicine at one of the top medical schools in the country. He walked with me and the team into that patient's room, and he said to her, "This is one of our young doctors." That is what we call them. They are here in medical school to learn to be doctors. That is what we do here. And if that is not good enough for you, then you really need to be someplace else, and we can arrange for you to be transferred to another hospital. That stuck with me to this day. It stuck with me when I was standing in that nursing unit, when that physician said what he said. about that patient in the story I shared with you earlier. So in that moment, and I'll say in that moment, not knowing what an ally meant, that was a commitment for me to always stand for people, no matter who they are or where they're from or what their background is, that you commit to stand for them. And that takes a lot of courage to be an ally. It takes a lot of courage. And I would say as an advocate, have bystander training so that you understand and you can make that stand, you can make that commitment, you can be that catalyst rather. And then you go back each time and say, what did I learn? Is there more I need to understand about myself? So then that brings us to this, what is racism? And since the killing of George Floyd, Breonna Taylor, and what is happening in this turbulent environment that we're in, when we hear words about racism and institutional racism and structural racism, I think it's important to understand what these terms mean. And here we're not talking about interpersonal racism, the races that we think about. What we talk about here is that it is a system that advantages some and disadvantages others based on what we think of as race or skin color, and is grounded in the presumption of white supremacy. Structural racism then are policies. There are organizational, institutional practices, how we represent ourselves in an organization. What are the norms in that organization, and how are they expressed throughout that system in an organization? And structural racism then, there is social, economic, and political systems that exist inside of these structures. And I always say to everyone, go back and ask yourself the question, in the system that you're affiliated with, how is this operating in this system? How are practices and policies developed? How are they implemented? What are the values? What are the norms? Who's representing those? Or as I always say in the play Hamilton, who's in the room where this happens, where policies are implemented? Whose voice is not in that room? Whose voice needs to be in that room? And then how we work where we are to make that happen. So the messages then around key messages from my friend Kamar Jones is that accept that racism does exist as a system, that it takes the energy out of the entire system. It takes energy from the entire society. It leads to indifference in how people are treated, that leads to less than optimal, poor backgrounds or death in the system. And that as patient advocates, as caregivers, we must act. At this point, we have to act to dismantle these systems. Well, what are some of the things we can do? Understand and document the impact. Understand the data. What are the lenses that we need to change so that we can see how these systems are operating? Acknowledge that structural racism exists, that it needs to be challenged, and that mass social movements, in particular Black Lives Matter, can help us through these challenges. And then look at the policies, have a voice in the policies where they can be restructured, rewritten, redone, or even abolished, so that we can move forward in healthcare. Well, Paul Batal and IHI, friend of mine, said every system is perfectly designed to get the results that it gets. So we need then to fix the system. So as providers, what can we do? First, providers and advocates need to be empowered through teaching, through shared decision-making, being empowered to remind people of their rights, to use communication styles that support a deeper understanding, I would say. And these are some of the things that I'm sure Eileen and Pulse has gone over in their campaign, ensuring care that goes on after the appointment. What are the follow-ups, lifestyle changes, medications, support, et cetera. In one system, I looked at some data just on pain management for sickle cell patients. And it turns out that this large database revealed that African-American men who came in a painful crisis would come in with a pain score of about 9 or 10. When they were discharged or went through the transitions to home or their next level, their pain level was still an 8. And in most of those cases, the follow-ups, the lifestyle changes, the medications, that care support system of having a team advocating for them post-discharge was weak or absent. So we need to make sure that we build a different kind of system that ensures this kind of care. What are some of the other things then we can do? And I do this for my family members now, and I'm sure as patient advocates, I'm preaching to the choir. Have someone else there. Have people with you. Don't leave your friend or family member completely alone. Make sure that at the end of an appointment that a person feels that they've understood. I have, again, another friend there in Chicago who would go to visits with a young man who was partially paralyzed. And in the visit, what she noticed was that the physician spent most of his time in the computer and not even looking at the patient. When she asked the young man about this and how he felt about it, his response, and I've shared this before, was that I don't have a physician, I have an accountant. When she asked the physician about the interaction, the physician said, "Why do you care so much? There's thousands more just like him." So an advocate means then to be present and say, he doesn't understand, or she doesn't understand, or she is afraid to speak to you or ask questions because of how you presented yourself. Doing the research before and after you go to a visit. Ask questions, ask why and why and why. Understand medications and understand the recommendations of that caregiver. Make sure that people understand that they have a Bill of Rights. There is a patient Bill of Rights, and that it's to their benefit. And then a key one is asking for interpretive services. There are ways to de-bias. We've talked about training. The other is intergroup contact. So that means being around people not like you, so that you begin to understand. And that requires a lot of humility as well. To understand, to take the perspective of others, to recognize, be sensitive, and to understand emotional expressions. When a medical student, an attending physician told me that he noticed that when he would go in the room, and this is in Birmingham, with Black patients, they would never look him in the eye. And they would have blank looks, and he did not understand what that meant. So we spent time talking about what an emotional expression can do, especially in the population that was being served here in Alabama and Birmingham back in the 80s. And then the idea of bringing in what's called counter-stereotypical exemplars. So if you don't have people in your system, then first of all, diversify your system. Be a more inclusive system. Next, advocate to bring in people who don't fit maybe a system stereotypes, and be open to learning. Seek to understand. As I said, it's better to be interested than interesting. So believe, listen, and join in the stories of people not like you. Look around the room and say who's not here. We have to move beyond systems who think that a person is quote unquote not the right fit for us, and say, well, we need to bring people in who are not typically in the room that can advocate for our patients and populations. I would say we have to act. My friend Kamar Jones says we have to organize, strategize, and act. And I would say a bit further, if we fail to act, if we fail to speak up, then that is a violent act in and of itself. We all have power. We have to begin to understand what that power is and how we can utilize that power to the benefit of families, the patients, and our communities. Again, back to action in and of itself is power. most often when I present someplace, there's always a person that comes up to me after a presentation and will say, I'm just one person. I know we need to change. I know we need to do better. I know there are biases in the system. I know that our system structurally and institutionally has some racist components to it, but I'm just one person. What can I do? So I would say that the power is in a collective, and I encourage you, you're not alone, that you're in a collective, and how you bring that collective to action in and of itself has power. And I would encourage you to use that power in ways that it's never been used before, because it's more urgently needed now than it ever has been before. And I will finish with just saying that is the hope that I have. And in the midst of everything we're in right now, I have a hope that we're moving in a better direction, that the momentum says this is our time to act. This is our time to improve these systems. This is our time to help people in ways that they've never been helped before. COVID-19 has unveiled all of the things that many of us knew existed pre-COVID, because the data, the stories, the experiences, the outcomes already existed. But I'm optimistic that with what's happening now, collectively, we can do so much more for our patients, for families, for communities, and frankly, we can change the world. And I say that, people say, oh, how can we change the world? Well, I encourage you, one way we can change the world is change the ground that you stand on first, and find that collective group and continue to work in that group. So just some references, and I will stop there. And I'm not even sure what time it is anymore, but I think we're doing okay on time. So I will stop, and thank you for listening.
Do you see anything changing in medical education?
So I do. I think I mentioned for, I think second, going maybe third year, I've been a part of this wonderful group at the American Council of Graduate Medical Education, where we have formal medical educators, residents, and their leadership that are understanding more about these topics and what can be done. So at the ACGME level, there's activity. Over the last year or so since COVID, I've talked to medical schools and systems about these topics and what they're doing, and universities that are now investing in education and training. There's education around structural humility and structural competency. The formal medical education groups are paying much more attention to this. It's always a challenge to get these topics into a medical curriculum, but I even see movement there. So that's why I say I'm so hopeful. And I would say part of that is the medical students and residents who are younger, who grew up in a really different world, want to know more and what they can do. There's a difference in how they see the world, and we need to do all we can to encourage them as they go through training, that they don't hit a wall, and what we call that is moral distress, when they want to do right for people, but the culture of medical training has not allowed it. So they come out of training where they model the behavior of the teachers. So I see that changing. So again, I'm very optimistic about it, and very hopeful about it.
Dr. Wyatt, this was a really touching presentation on so many levels. I have recently embarked on a journey as a teacher. I'm an assistant professor at the College of Nursing and Public Health, and was recently selected as a teaching fellow. And I'm currently learning and designing simultaneously an intervention for nursing students, for senior nursing students. And so it's a really big opportunity, and faculty, staff, and students are really, they're open into integrating diversity, equity, inclusion, and anti-racism into the curriculum because it's so important. And you spoke about allyship, and I think, you know, there really is so much that I want to give the students, but for me, I really wanted to give them the voice of allyship as one tool that they could walk out with. But I just maybe wanted to hear a little bit more about structured humility because I've really been thinking about cultural humility, but structured humility is something I'm going to investigate more.
Yeah, so structural competency and structural humility are I would say a movement forward from cultural competency.
Mm-hmm.
And I really think it applies in the clinical setting where a person begins to understand the structures that a person is involved with when they come to see us. Again, political, economic, social. We need to understand more about that in order that we can then deliver better care. And part of that, the humility part, is to listen, to build the trust and to listen with empathy so that what people tell us, we receive it and then integrate that back into the care and the decisions that we make. And that's the humble part of that. And that's a lot of that is self-reflection. It's a commitment to lifelong, kind of instant debrief. Like, what could I have said differently? Was that the right thing to say? Was it said the right way, with the right tone, with the right posture? So increasingly, even back to medical schools are beginning to teach structural competency and structural humility. And Northwestern there in Chicago have already started to do this. And they're actually integrating this into their master's program of quality and safety. So that you begin to understand more about a patient's experience, a family's experience, and how it impacts the care that they are given and the decisions that are being made.
Yes, Dr. Wyatt, I really am so grateful for your presentation and your case studies that you presented. Every one of them was heartbreaking. And truly, I think that the thing that absolutely scares me about this whole COVID issue has been that there's been this a stampede to remote medical visits. And the one story about the woman who was pregnant and ended up dying because she could not get a physical appointment. It is a fear of mine that many people either don't have access or don't trust the access or are deferring that access. And therefore, we are going to have an epidemic of loss following COVID because people have just deferred their medical treatment. And, and that goes across the board. It's probably more evident in places where there's limited access. But I think across the board, people are just deferring their medical care just because they've lost that contact. And I don't know what we can do to remedy that and make people feel more comfortable with saying, no, I really need to be seen,
Yeah, and I agree. Those concerns are real and they're happening. I would say the company I work for, MCIC, is one of the largest medical malpractice companies in the U.S. And we've already seen claims from people who could not access a visit and a diagnosis was missed. There are acute concerns about telecare making disparities worse and increasing inequity, and particularly for marginalized populations, but also that includes elderly populations, elderly rural populations that can be impacted. There is what's called Project ECHO. I'd recommend you look up and see how Project ECHO is beginning to reach people who are remote, that can get good care. Their physicians can access Project ECHO, but there's a real concern about how we structure telecare in a way that we don't make disparity worse. I agree. I have to share a story, and it's an advocate story, and it's personal. My brother has stage 3 multiple myeloma. He went to a hospital in Northern Virginia. My brother works for one of the big government agencies at a supervisory level in the DC area. He was taken to a hospital by his wife in septic shock, got put in the ICU on pressors. 3 days later, they were discharging him. When he was in acute renal failure and had an allergic reaction. When his wife picked him up, since she couldn't go into the hospital, and my brother is nearly obsessed with being clean. He irons his blue jeans. He might even iron his socks, I'm not sure. But when she picked him up, she called me and said he was filthy. They had not given him a bath during that hospitalization. He looked at her and started crying. And he said to her, "I don't want you to see me this way. I might as well be dead." So I talked with him. I called the system hospitalist chief and ultimately the CMO of the system and explained to him how he had been disrespected, how he had been treated. My brother is not one of these people that's going to go and say, "I was treated that way because I'm a Black man." But when I talked to him, what he said was, "Did they treat me this way because I'm a Black man?" And he even said to me, "I don't want to think that, but that's all I have left now because I can't complain about the care. They treated me like I was a checklist, not like a person." So in his case, I was that advocate to say, you failed him. And one of the first things you need to do is apologize to him and to his wife, and then go back and do the work in your system to understand how you failed him. When he went to see his dentist, who was an Asian female there in Northern Virginia, he told her the experience. She told him she almost died during childbirth at the same hospital, and that the Asian population around that hospital told each other not go to that hospital. That's the impact that leadership need to hear, how it's impacting them. So in that case, I was that advocate. So I would say, as we find out these stories about people who are in care, particularly in COVID, family members, ask the questions, is there a patient family advisory council who is advocating for people? And if there aren't, then we have to set up systems so that collective action can take place in real time. I wish we had patient advocate rapid response teams, even that someone could trigger and say, we need your help. We need your voice. We need you with us. And that would be my dream of dreams, to see that happen. Thank you all so much.
Dr. Wyatt.
Thank
Thank
you.
you. Thank you all.